So, welcome everybody. Thank you for coming to our 5th Tuesday webinar. We were out traveling in New Mexico as a team, offering technical assistance to a couple of programs out there. We're very excited to have Judy Dahlstrom and Brandy Lineberger from oh my goodness. I just read population health and then forgot partners in Gaston, North Carolina. Judy is the program manager, program director of their SAMHSA grant in implementing AOT. They've been they're part of the 2020 cohort. And then Brandy is her colleague at Partners and is the unique thing about this program is that they have a focus on this social determinants of health. So I thought that it would be really interesting to hear them talk about that. I also want to encourage you all, if you have something unique about your program and would like to talk about it, let us know, and because we have many open webinar spots. So I'm going to introduce Brandy. I introduced Judy, and that's about all I know about Judy, other than she's lovely to work with. But Brandy, I have an introduction for. So Brandy Lineberger is the population health manager at Partners Health Management. She attended Gaston College School of Nursing and Western Governors University and is a registered nurse, faith community nurse, and certified dementia practitioner. She has worked in various areas as a nurse, including intensive care, home health, hospice, long-term care, geriatrics, and behavioral health. Brandy has a true passion for behavioral health and population health. She has served as a member of the North Carolina Institute of Medicine Older Adults Task Force, the Council on Aging, and the North Carolina Home and Community Block Grant Advisory Committee in the past. She also serves on many population-focused work groups dedicated to improving lives of the entire population. So thank you. I just want to let everybody know that I am going to post the slides in the chat box, and then we'll take questions once the presentation is done. You can either put them in the Q&A or in the chat, and I'll be monitoring both. So take it away. Brandy, you're starting, correct?
I am.
Great, thank you.
You're welcome. Thank you for having me. I'm so excited to be here today and to be able to present to you all. And the social determinants of health is something that I feel very strongly about and very passionately about. Is something that can really make a difference in the lives of those that we serve that have severe and persistent mental illness. And so we want to make sure that, as we address these things, that we cover the whole person and that we make sure that, people's needs are truly met and that we meet them where they are in the recovery process, whether it be for substance use or whether it be for mental health. So I'm going to share my screen. And if I could just get a thumbs up, letting me know that you all can see it. Thank you, Judy. All right, so here we go. So I am from Partners Health Management. I have been at Partners Health Management since 2012. In my former role, I was the Geriatric Adult Specialty Team Program Coordinator, and I spent a lot of time providing education and training and technical assistance in the community for the agencies that provided care or assistance to individuals that were older adults. And just to tell you a little about Partners Health Management, we are a managed care organization, and we currently manage the behavioral health and intellectual developmental disability services and substance use services for individuals with Medicaid and state funding. And we currently manage 14 counties in North Carolina. We grew recently. So I'm going to start with talking about what the social determinants of health are. And so when we think about the social determinants of health, that is the conditions in the environment where people are born. It's where they live. It's where they work. It's how they worship. It's their faith. It's, you know, a wide range of things. It's their functioning. It's their quality of life. It's the risk that they have in place. You know, when you're born, you have certain risk factors that are genetically there. And then you also have things that are socially there that are in your environment that can affect you and can affect the way that you live and work and play in the environment you're in. The social determinants of health also can contribute to disparities and inequities in the community. And Healthy People 2030 does identify the social determinants of health as one of the top 5 goals that we need to address. And I feel very strongly about the social determinants of health because I have firsthand seen how someone can be either successful or unsuccessful based on the hand they're dealt and the equity that they're allowed to have. And so social determinants of health and physical health care. So I just want to talk briefly about how access to health insurance, health care, et cetera, can affect the physical health. So if I'm an individual living in the community and I do not have the ability to go to the doctor because I either don't have money, I don't have insurance, or I simply don't have the access. Maybe I live in a very rural community and I cannot get to the doctor, so I have lack of transportation. That might cause me to unintentionally neglect my physical health. It could also cause chronic health conditions such as diabetes, hypertension, or even, you know, schizophrenia, bipolar disorder, et cetera, to be neglected. I may not be able to get to the doctor or to get that health care that I very much need to be able to be healthy and well. And then also the inability to access prescription medications. So I commonly hear people say, you know, well, this individual has Medicaid, so, you know, they should be able to get their prescription medications. But what we have to remember is that sometimes there's a copay associated. In North Carolina, for a lot of the medications, there's a $3 copay. $3 is a lot of money when you have no money. So, you know, you have to take that into consideration. And then you also have to take into consideration the fact that you have to have transportation to get to the pharmacy to pick up your medication, right? So that can also be a barrier to being well. And so to talk about the social determinants of health and mental health, a focus on social determinants of health can lead to better mental health outcomes. It can include preventing mental illness. We know this. This has been researched and proven time and time again. It's also been suggested that people that live in higher poverty areas may have negative mental health outcomes as opposed to those who live in lower poverty areas that might have more positive mental health outcomes. When we think about that and we consider how the area the person lives in can affect equitable health access, it's a big factor. The thought is that being directly related to a lower accessibility is job opportunity. And so as many of you know, jobs and being able to work and have a healthy work atmosphere is very important to how your mental health you know, it's very important to that person's measure of success many times. A lot of people are raised to think if they don't have a successful job or work environment that they're not successful. And so if you think about individuals that live very far out in rural communities, they may not have access to have that healthy work environment. So that's another factor we have to consider. And then when you think about how the SDOH can affect mental health, SDOH factors that can impact health positively: affordable and equitable housing access, access to affordable, healthy food options, improving the environment that the individual is exposed to regularly, improving community cohesiveness, economic integration into neighborhoods, and then access to safe areas for positive active living. So what I think about with some of these, for example, with an environment that individuals exposed to regularly being healthy and a positive environment. Think about a community that's not safe. If you can't take your children outside to the park, or if you yourself can't go for a walk in a healthy area, that can have an effect on your mental health. Also thinking about, access to safe areas for positive active living. When you think about that, you think about, healthy areas to be able to be, at work possibly, or a healthy place to live, or, a safe place to live. That's very important too. Another thing I think about is with the environment is the exposure that can happen. So having a healthy environment to live in, as far as like not being exposed to a lot of pollution and things like that. Those are things we don't always think about, but those can definitely have an effect on health as well. And then the social determinants of health and substance use. So that plays a very big role in being healthy and successful with a recovery. Health disparities can have an impact on successful recovery. Cultural specific, trauma-informed, and resilient supportive prevention services can help reduce health disparities and promote equitable access to treatment for substance use. That's really important. I always make an emphasis on culturally specific and trauma-informed, because as this group very well knows, trauma is at the bottom of a lot of people's barrel, so to speak. They don't treat it up front, and I feel like trauma has such a huge effect on mental health. It really needs to be one of the things that we treat on the forefront. And then I want to talk very briefly about the screening tool. Judy is going to go more in depth into the screening tool, and she's actually going to show you an example of what the screening tool looks like and the questions that are on there. But when we look at the screening tool and we utilize it, we look for not just past needs, but also for current needs. So it's important to know what that person has faced in the past 12 months, as well as what the person's currently facing right now. So we look at not only does the person have access to food now, has that food issue been, food access been an issue in the past? That's very, very important. And then also housing. Do they have safe housing now? Have they had it in the past 12 months? And then of course, utilities, health insurance, employment, and then safety too. So we look at all of those currently and in the past. And that's very important as we look at the person's holistic health. And then social determinants of health. We look at tailored care management demonstration. So tailored care management demonstration is something that I have really loved being a part of at Partners. It was a pilot program that began in early 2020. We used a focused care management model, and this was basically where we looked at individuals and they had to meet certain criteria to be able to be a part of the pilot program. And part of that was having a severe and persistent mental illness or a substance use issue, and then having some other health conditions in place. So it may be an individual who has bipolar disorder and also has diabetes, or has a high BMI, or maybe had hypertension. And so what we did is we put those individuals into this focused team-based care management model. And we had whole person integrated care principles that we applied. And so we did very, very in-depth things with these individuals. We contacted them very frequently. We had a care manager that was specifically assigned to that individual. They were able to contact that care manager when they needed to talk about their health, or when they had a social determinant of health issue that came up, or when they maybe had a doctor's appointment and didn't understand what the doctor was telling them was going on, or maybe if they had a test that they had a lab test or something, they didn't understand it. The care management was the center of helping make sure that that care was coordinated for that person. And we found some really interesting things with that model as we did that pilot program. And all members that participated in the tailored care management demonstration, one of the screenings that they had was the social determinant of health screening, among many, many other screenings that they had completed. But what we found is that when we performed the SDOH assessment, that, you know, there were social determinant of health needs that were revealed to us, and we were able to help connect that person. And so we tried to use closed loop connections where we referred them out to a resource and then followed up with the resource to make sure that it wasn't just a blatant referral, that it was a successful, true closed loop referral, and that that person did have their needs met. Such as, you know, a lot of times we'll refer somebody to a food pantry, right? But we don't know, did they actually go? Did they get food? We don't know. So the care manager tried to follow up with these individuals and make sure that that was a successful referral and that it wasn't just a blind referral with no after assessment, or, you know, no true knowing what happened after that a referral happened. And then as far as the assessment itself, so when the person does the social determinant of health screening, they have 3 or more needs that are identified, then it automatically triggers that they need a plan, or if they have specific indicators. And I'll talk about the specific indicators again in just a moment. Members are screened at baseline and then approximately biannually. I will add a disclaimer. We did find through the tailored care management demonstration that sometimes people needed screenings more often. So they would talk with the care manager and they would say, well, I had to move, or, you know, I lost my job, or, you know, I didn't get my check on time, or, you know, for whatever reason. And the care manager started realizing, hey, we might need to, you know, when they have these specific situations that come up, you know, that's a cue to us. Oh, we need to do another SDOH screening and get these needs met that, you know, this person's identifying. So in some cases, it really is as needed. It's more of an as needed. So I would say minimally baseline and then biannually, but certainly more often as needed. And then provider assessments that are completed are loaded into our care management system. And then tasks and actions are triggered from the responses in the assessment that the individual completes. And then triggers happen. So if the person, for instance, identified a need for prescription medication assistance, food, and housing, they're going to trigger right away, and they're going to need a plan. And so the care management then works with the whole team, the team-based care model. They work with the whole team to try to implement a plan and to address the needs that are identified during the time that this screening is completed. On average, in fiscal year 2020 to 2021, about 17% of the total assessments that were completed identified 3 or more needs or had an acute indicator. And an acute indicator was usually safety. So if they said they had a current safety issue, that was an immediate, it didn't matter if they had anything else that triggered, the care manager would immediately jump into action and try to get that person what they need in place to be safe. But 17%, that's, you know, that's a fair amount there for that group. Beyond the social determinant of health screening tool. And so this is just to talk about some of the other data that we collected to narrow down the top needs in every county. So we do use public health data. We use community assessments. We use risk stratification or population identification as well. We'll look at our population and kind of form buckets, so to speak, of individuals that have this need or this health condition or that health condition. And then we try to put things in place to try to help that person to be more successful. We do surveys of the community, surveys of the providers, and then we also have what we call a CFAC committee, Consumer Family Advisory Committee. And so members of that community that committee are from the community. A lot of them either have had a substance use behavioral health or IDD condition, or have a family member who has had it. And so they're able to provide us with great, wonderful feedback and to try to help us to make sure that we stay on target as we address the needs of the community. Now I want to talk about quality of life. And so Judy on the call, she knows I speak of quality of life a lot. As you heard when Amy read my bio, I was a hospice nurse in past life. So I have a huge focus on quality of life. I think it's really important to look at that person and look at the experiences they're having and try to ensure that they're living their best life, right? That's the goal. And so a part of that, you got to look at health equity. You want to make sure that we try to provide everybody with the same opportunity as possible, the best, opportunity as possible to live their best life. And so the social determinants of health is one small component of helping achieve health equity. The other thing we look at is length of life. So you want to look at, helping that person live the best long life that they can, right? As long as they can, and be as healthy and well as they can for that time. And then you also have to look at rates of disease, disability, and death. And then we have to look at the community health. So we have to look at the whole health of the community. And then we also have to look at prevention and wellness. The best way to, work on chronic health conditions is to try to prevent them in the first place so they don't occur. So you want to work on making sure that you try to keep the community as well as possible. And so there's considered to be 5 domains. And so the CDC talks about the 5 domains of health very often. And what they mean by that is the built environment. So that's the structure of the environment the person lives in. That's where the CDC does what they call walkability surveys. That helps them to know how easy it is to access sidewalks and getting from, the grocery store to the post office back to their home. So they look at that. And then they look at community clinical linkages. So they look at the access to care in the area, the access to health care, primary care provider offices. They look at therapist offices. They look at dietitians. They look at all the different healthcare providers and try to make sure that people have equitable access to that. And then food and nutrition security. If you go back to Maslow's hierarchy of needs, food and nutrition security is at the top of the list as far as, having needs met, right? So you gotta make sure that those things are met. And people can't be well in their mental health journey if they're not able to access good food and nutrition. And so, as you all know, a lot of our individuals that we serve that have severe and persistent mental illness struggle with food and nutrition security and having healthy food access. So, that's something that we worked on in our tailored care management model, was trying to make sure that those individuals were educated and knew how to access or, were able to access those good, healthy food and nutrition sources. Social connectedness. Feeling of belonging, right? That's important to all of us. All of us like to feel like we fit in and we have a place. And that's really important for our individuals that we serve that have severe and persistent mental illness as well. We want to make sure that they feel like they belong and they have a place in the community. Tobacco-free policies. And I know some people will be like, wow, why is that in here? So tobacco has such a profound effect on chronic health conditions, period. So it's really important to include that when you're looking at the 5 domains, and that is one of the 5 domains that the CDC supports and encourages addressing. And so it's really important that you look at that as well. Challenges and barriers. So these are things that we encountered as we did the tailored care management demonstration with the social determinants of health. Z codes. So Z codes are awesome, right? If the physician will code them, they're awesome. So they are codes that can maybe identify homelessness or food insecurity or, some of the more chronic situations with their family, family dynamics. So if you can get the physician to code the Z codes, that's a home run, because then that can translate into data analysis. And what you can do is try to hotspot and figure out where the Z codes are the most concentrated. And then you can actually perform an intervention and do something about it. The other thing is member completion. Given a clear reason to the person that you're providing the screening assessment to. So if I'm the care manager, if I'm the nurse and I'm providing an assessment, or I'm the social worker and I'm doing an assessment, explaining to that person why I'm doing the assessment. These questions can be pretty invasive. And, I don't know about y'all, but sometimes when somebody's asking some of those questions, you might think, they're being awful nosy. Well, we're not being nosy. We're really trying to help them. So giving them a clear reason why we're doing the assessment so that they can be as, honest and transparent with us as possible. And then explaining when the needs will be reassessed. So let them know, we'll only do this twice a year unless you identify a reason why we need to do it sooner. And if you let me know, then we'll do it sooner and we'll try to meet your needs. We'll do what we can to connect you to resources and make linkages to care. So letting them know up front, that's what this is about. And then as far as provider implementation, one of the definite challenges we had was some providers not using the same standard assessment tool. And so that's really, really important. Asking the same questions across all areas. So if, using the DHHS list of questions is the best thing to do, because then all providers are on the same page and it's very standardized, and then you can actually perform that data analysis and then again do that true care linkage that needs to be done. And then also assessing on the recommended time frame. Just as important to identifying the needs that are there and completing resources linkages and referral linkages is also reassessing to say, okay, they had this need 6 months ago. Is this still a need? Is this better? Do we have new needs? So you can do a comparison. So it's really, really important. And then understanding the necessity of implementing a plan. That's also another challenge that we saw, is just making sure that the providers that are providing the screening tool or the assessment understand and know why it's important to implement a plan when those needs are identified, and why it's important to follow up and make sure that the needs were met, right? That's super important. Opportunity. So as a part of recent work to reduce inappropriate utilization of the emergency department, I was able to identify that a lack of social determinants of health assessments correlated with the very high future risk of emergency department utilization. So by looking back and doing some data analysis, we were able to really see the individuals that consistently utilize the emergency department inappropriately, they did not have a social determinants of health assessment completed. So that tells us something. That tells us that, those social determinants of health have a real factor into if that person is seeking care at the emergency department and they're not able to get care outside of the emergency department, possibly. Many of these individuals also had multiple chronic illnesses, both physical and behavioral in nature. And we're currently in the process of using the data to guide care opportunities with this population. So that's something I'm excited about as a nurse. I'm a fixer. So if there's a problem, I want to make it better right away. And so this lets me put my interventions into action and try to help people. And so some of our next steps, as we move to a tailored plan in December of 2022, we will assess every single person that's a tailored plan member that is a part of our managed care. We will use Z codes to further identify hotspots or areas of increased need. That will help us to identify areas of, that have a lack of food, security, housing, etc. Services will be enriched to meet identified needs in specific communities. For example, The SDOH assessments indicate a need for housing in a specific county. Z codes could identify similar needs in the same area. Then we could obtain housing or help individuals to obtain housing that's available, but we could also seek grant opportunities because we can use data to support the need. And then that's how you utilize data-driven decision-making. And so that's super important, today as we move through the process of helping the community and helping individuals that have severe and persistent mental illness. And that's the resources I used. You'll see that on your PowerPoint that you're able to access. And then I had questions. So if anybody has any questions, they can certainly add them in the chat and I will do my best to look over those. Or Amy Judy can help me to pick out those ones and answer them.
So,
and then this is my contact information.
Excellent. So Judy's got a portion. Should we do the Judy part and then go into questions?
That should be fine, I think. What do you think,
Okay.
Judy?
Yep. Great.
Let me stop sharing my screen.
Okay. Hi, everyone. My name is Judy Dahlstrom, and I am the project director for our SAMHSA grant for assisted outpatient treatment. We are, like Amy said, in the 2020 cohort, and so we've just been really active for about a year. And I want to talk a little bit specifically about how our grant works with what we call members, AOT members around social determinants of health. And so what we did when we were writing the grant was we included dollars for addressing social determinants of health. So when a member is enrolled in assisted outpatient treatment, there is an intake screening that's conducted, and then we do our screenings every 3 months thereafter. Right now, for the most part, a lot of our folks are not being held on the court order much longer than the 3 months. So some of our data is not where we need it to be. But like I said, we're just a year into this, and we expect some of that to change over the next year or two. I'm going to share a screen with you to show you the form that we used to develop ours. Everybody can see that, I assume. Thumbs up, Brandy. Can you see that? Okay, thank you. So this is the form that was recommended by the North Carolina Department of Health and Human Services. And I wanted to show this to you so you could see kind of what the questions are, and also to tell you a little bit about how we tweaked it for our purposes. And so the categories are the same: food, housing, utilities, transportation, and safety. But like Brandy was telling you about, we added questions to each of those. And so rather than just asking if food was a problem for you in the past 12 months, we added a second question that said, is it a current problem? And then we did the same thing with housing. Has housing been a problem 12 months ago and is a problem now? So for each of those questions, we know if there's a history or if it's just a one-time kind of issue that's occurred now. And that gives us a little bit better information. For our purposes, we decided to do the screening tool that way so that we could put our best and put our resources into something that's happening right now. And so if housing is an immediate problem, we want to know that. And so that if somebody's in a session in treatment and a person's being worked with, but they're really kind of absent because they're not sure they're going to sleep tonight, it's really hard to know. It's really hard for treatment really to kind of take hold. So we've really found that addressing those current needs, especially around food, housing, and safety, are very imperative to getting better and entering recovery. And what we did at the beginning of our grant was we developed a list of what we thought people would need help with. So things like food, temporary housing, emergency food, money for utilities, transportation, cell phones, and data plans. Those were the things that we identified as things that we wanted to be able to help with for a person on an outpatient commitment order in AOT. So we developed guidelines for each of those categories and procedures around how to acquire that support. What we did was we had members in AOT work with their peer support specialist to complete a financial request. So we were able to get a kind of a list of what their finances looked like, and then make a request to help with those needs. All of our staff know that they are required to look elsewhere in the community first for resources. So it's been interesting during the pandemic, there have been more resources available than were before. And so things like food, we're not spending the money on that we kind of anticipated at the beginning of this, but our staff, like I said, do look at community resources first. Once they submit a financial request and a request for the particular assistance, we have a clinical supervisor in AOT who sends that to me after he preliminarily approves it, and then I approve it. We kind of have the mentality that unless we can think of a really good reason to say no, we are going to say yes. That if somebody needs help, we're going to find a way to help them. And generally, we have been able to turn those requests around within a few hours. So if somebody makes a request this morning for a cell phone, for example, we kind of keep one in the hopper in my office, and staff know that once it's approved, they can go there, pick it up, and the person has a cell phone that night to stay in touch with the people working with them. We know that urgent needs and gaps require an immediate response, and we've committed to making sure that happens. Like I said, we have in AOT a baseline of only 26 baseline screenings, which is kind of where we thought we would be in the first year. And for those 26 baseline screenings, the average number of needs for those folks was 6.8, which is really pretty high when you're looking at the needs that our members have. It kind of reinforced for us what we knew, that this population is highly vulnerable and has some immediate needs. So that was not really terribly surprising. For our follow-up screenings, though, that has been something that we did not anticipate. We thought that after 3 months in AOT that some of those SDOH needs would come down below 3, but we found that 3 months and 6 months later, we still had more than 5 current needs. And so that's something that our data is pointing us in the direction of doing better on. But we know that part of what happens with this population is that when those initial baseline screenings are done, they're usually at the end of a kind of a crisis where they've been hospitalized involuntarily. And then 3 months later, we know they have a little bit better insight into their disease and into their illness. And so that could be a reason. The other reason is we don't have a lot of longevity for people staying in AOT. And we know that that is really kind of key for sustainability. That's really what our process has been. As an agency, like Brandy was talking about, we are able to use the data for the SDOH screenings to make informed decisions and develop some of the resources in our communities to assist all of our folks. And I don't know how many screenings have been done in our agency since we started this several years ago, but it's I would guess did a little bit of what Brandy's doing now before I became the director of this AOT grant. And so I would think that we're looking at tens of thousands of SDOH assessments that we're able to gather this data from. So it's been a wonderful effort and very meaningful for our members. Maybe that is the end of what I wanted to share.
Excellent. Well, thank you. There's a number of questions. One was about Z codes, and I noticed Brandy put something in there, but can you just say so?
Sure. So Z codes are what we would consider the social determinant of health codes, and they're part of the ICD-10 codes. And anybody that interacts with that patient or that member can enter Z codes. It could be social workers, community health workers, case managers. It could be a nurse navigator or a patient navigator. And it's basically just the codes that are entered in that identify social determinant of health needs. And so part of that is if those codes are entered, then we can go back and look, and we can use those as a part of data analytics to help make sure that we are truly serving the areas that need to be served through hotspotting. Does that help?
Yeah, and can I add something to that, Brandy?
Yeah,
so,
absolutely.
And what she's talking about is actually for billing purposes. And
it is.
Okay.
Mm-hmm. Yep.
Yep.
So you mentioned the pilot program. Did you collect any outcomes for the pilot, and what were they?
The pilot is actually still in process. So we have Dr. Walby, who is completing the evaluation. And so he's just now finishing the first year evaluation. And so we don't have the results yet, but I can tell you from what I see, it does look like we're going to have positive outcomes.
What kind of things are you measuring? Just curious.
So we look at PHQ-9 scores. I know they look at the World Health Organization, the WHO-5. They look at the DAS-10, the audit. So they look at all those things. And then we also, of course, look at the SDOH. And then, just looking at in general, if the person's engaging in care better, if that person's having less emergency department visits, are they engaging with their healthcare team better? Are they having better compliance with medications? So all of those types of things.
There was a question on how many people are in the AOT program, and I think you said 26.
We had 26 at baseline, and right now we have served 31 in the 13 months that we've been accepting referrals.
And Judy, correct me if I'm wrong, but everybody in the AOT program gets an SDOH screening, correct?
Yes, everybody at intake and every 3 months.
How is the access to some of these resources that so many areas are lacking? It must be a real challenge.
It is, and like I said, resources have been a little bit different in the past year and a half. The other thing that we use on an ongoing basis, our care managers, not just in the agency as a whole, is something called Aunt Bertha. And it's a portal that anybody can use to find resources. And it actually, if I'm not mistaken, it's been a little while since I've done this, so Brandy, correct me if I'm wrong, but it does that closed loop so that a person, when they go to the food pantry, a person at the food pantry can close the loop on that person so that the referring person knows that it was completed. That's one of the reasons that we provide cell phones, because we put the Aunt Bertha app on that, as well as something called Pix Health, which is a little program that stays in touch with our members.
Yeah, that's true. And Pix Health, just to follow up on what Judy said, Aunt Bertha is awesome within itself. And then we also can use North Carolina Care 360 as well. And it has closed loop referrals, and it actually allows providers or professionals to engage with each other and talk back and forth, sort of as almost like a messaging format, sort of like chat. And then also another thing with the PICS Health, it does reminders of doctor's appointments, medication reminders. It has an interactive, what we call an Andy. So it's a person who will call and talk to that person. It also has activities. So really great tools that we have that we're able to upload on those phones for the individuals to utilize.
So are you able to address the underlying causes for, so, you know, I understand that you make referrals to a food bank for food insecurity, and that you are able to provide temporary housing. What about long-term housing? What about addressing food insecurity, again, from more basic framework, so that you're addressing the issue long-term?
So I can kind of answer some of that, and then we'll let Judy tag on too. We do a lot of connections to workforce development and to educational resources. So I know through the SDOH, we've identified a lot of individuals who are interested in workplace readiness. So they want help with being connected to the local community colleges for, you know, vocational type programs and things like that. And, you know, getting them engaged into, you know, a work environment that's a positive environment, and getting some financial help coming in as far as, you know, funding, you know, money wise, that helps to solve some of the SDOH needs that are there and in place. I do know through the tailored care management demonstration pilot that we've done, we've been able to identify some individuals who needed to be able to get Social Security disability started. And so they were able to be connected as well. Do you have anything to add, Judy?
Probably. That's a really hard question, Amy, because we do essentially put a Band-Aid on what we need to deal with right now. And we know that the real answer is putting resources kind of upstream. And so we kind of do both as much as we can. Like Brandy said, with our program, with the AOT program, we have a SOAR specialist, which works with members to get benefits. But we also know that something like getting well and becoming employed trickles down to having a place to live and being able to have food. So it's kind of a combination of all of that, although it's not an ideal situation that we can, you know, take care of somebody's housing for the rest of their life. I understand your question. And like I said, it's a little bit of a Band-Aid other than trying to work on things upstream.
Yeah, I would agree, Judy. You know, a lot of times you do, I guess, essentially the best with what you have, and sometimes it's still not enough, and we recognize that and you know, own it, that there's definitely, we can't solve all the problems, but we're certainly trying to start small and working to do what we can to help where we can.
People want to know if everybody has an Aunt Bertha or just North Carolina.
No, it's a national, it may be even international, and really you just can Google Aunt Bertha and put in a zip code, and it will start to sort what you're looking for, and anybody can use it. It's completely free. We do have a contract with them where, and Brandy, you're going to have to finish this my sentence almost, because it's been 2 years since I've worked with Aunt Bertha, but we work very closely with them and have set up kind of a partnership with some of our local providers that can be entered into the system. And I don't know if you want to say any more than.
Yeah, so what we actually have is sort of like a portal, and it's a portal for our area, and it allows people to be confirmed as, you know, partners. So when they go in there and they enter their information, they can say, please include me as a community partner in these counties, and they can select what counties they serve. And so that allows them to be confirmed. And then we know that they're a valid, true community resource that we can rely on for referrals and resources. And, you know, pretty much nationwide, that is the case for most states. They have what we would consider a confirmed area.
Cool. I've never heard of Aunt Bertha before.
And I did, Amy, I put the link in the chat, and it's actually Find Help is the way it comes up. But if you Google Aunt Bertha, period, it's Aunt, like AUNT or Aunt, and then Bertha, BERTHA. And if you Google it, it'll pop up. But the link I put here actually links, you can choose your state.
Excellent. Thank you. Thank you.
No problem.
So Leslie asked, it sounds like this is a good program and this likely helps to ensure the members' basic needs are met. We already answered that. 3 months in AOT, do some end up staying longer?
Some do. Of the 31 that we've served, 7 have stayed longer. One up to almost a year. But the issue that we have with that is more around educating our courts and the need for a longer outpatient commitment order, and that having that is not necessarily a failure.
Yeah, we're working on it. That's for
We
sure.
are, aren't we, Amy?
We really are. And Paul asks if a score of 3 or more is based on the 5 core domains or the core plus the supplemental domains.
You want me to take it, Judy? I can. Yeah, so it's going to be the core plus the supplemental. So we don't just look at the current, we look at the 12 months too. The 12 months will be considered the supplemental.
Got it. I'm looking at both, so hang on here, gang. So I'm curious, Judy, you said that in your grant, you have money for these things. Any ideas on how you might sustain that? Because it's nice to have the grant money, but at some point, the grant is going to move on.
No.
Okay, so
No.
hive mind, if anybody has any ideas, we're all ears.
Let me rephrase my no. So no, but we do get dollars from our counties that are used for local kinds of projects like this. We've got a little bit of that right now available for some things. And I think that as we become, as we collect our outcomes and know what this is going to look like in savings, that something like that could be added to our operation budgets as an agency.
Yeah, I mean, and the interesting thing about partners is that they're a managed care organization. They're not a provider.
Right.
So making clear the benefits and the cost savings are going to be instrumental in.
Right. And just, sometimes just having people not go to the emergency department and contacting their case manager saves us money. And when we can start to demonstrate and illustrate that, we have a real good case for having it included in a budget.
Yeah. And just to kind of add on to what Judy said too, I'm going to jump to my quality of life soapbox. So, I mean, what kind of an environment is it? And I'm preaching to the entire choir right now, for these individuals to have to continue to go back to the emergency department where their needs are continually not met by no fault of the emergency department, but they are not able to meet the needs of the individuals, on a long-term basis. What better way to try to do that than to get them engaged with a community provider where they're not having to end up in that situation where they can decompensate so quickly. in the emergency department. That's definitely, one of the things I think about.
Another thing you mentioned was tobacco and making sure to include that in the assessment. Do you all have tobacco cessation programs that you can funnel folks towards? And I'm wondering if you've utilized them very much with the AOT program, because we know that people with SMI have a much higher rate of smoking than other populations.
Right. And Brandy knows more about what programs are available, and our case managers do encourage our members to engage in those programs.
Yeah, so just to kind of double up on what Judy said. So we do at Partners, as soon as we're tailored plan, which will be December of 2022, we'll be required to offer tobacco cessation programs to everybody. But we're already doing that in many of our areas. Providers that provide services and receive Medicaid funding in North Carolina, all of those will be required to have tobacco-free campuses as of July 1st, 2022. So we're making progress there. And as a part of that, there have been some grants that have come along with our SOAR funding, the state opioid response money for tobacco cessation, to several of our providers. And they're able to provide the nicotine replacement therapy to individuals free of charge. So that's a really great thing to have in place there. And as y'all know, many of the individuals may meet those, diagnosis requirements too. And so we can also do referrals to Quitline NC. That is a statewide program that offers counseling, therapy, et cetera, lots of support for individuals that are on the journey to stop using tobacco products.
So, just so everybody understands, Judy, could you explain your AOT programs work with mental health providers, since you are not a provider yourself, and how that works?
Sure. So we have hired my position, which is the director position. And when I say we, Partners has hired my position, a clinical supervisor for AOT, and 2 teams of case managers, peer support specialists, and then those 2 teams share a SOAR worker, a SOAR benefit specialist worker to work with the members. And when we receive a referral, our internal teams work with them on mostly social determinants of health initially. And as things progress and things become a little bit more stable for them, we make referrals and work with our local providers. And the local providers that we work with are contracted with us already because they provide Medicaid services and state-funded services through contracts with Partners. And so we've got those relationships already in place. We did a little bit of contract addendums to talk about AOT and to emphasize what the mission is and what responsibilities are. So we have a natural linkage to the providers that have been long-standing. We know most of the people that we work with, and the members then, depending on the length of the outpatient commitment order, are referred to those community providers to kind of take over the treatment piece of things.
And they also, so even though you're addressing the SDOH for the 30-day or the 90 days that they're under the order, the treatment team picks up, I'm assuming, and in terms of
Yes,
permanent housing and things such as that.
right. Most of our folks qualify for ACT services, which is kind of a bundled service that, takes care of all of what it is they need.
So I'm looking to see if are there any other last questions? I think we got all of them. If so,